we figured we would start this presentation with a little recap on the background of normal pregnancy, parturition, and what to look for in a typical foal. On average, the gestation length is about 340 days, but this is dependent on different factors. For instance, if they're bred in the late winter, they will have a longer gestation length than summer, and males typically have a longer gestation length than female. There are 3 stages of parturition. Stage 1 begins with the first clinical signs and ends with the rupture of the atlantochorion, and this stage usually lasts about 30 minutes to 5 hours. The second stage is a bit quicker and ideally occurs within 20 minutes. This lasts from the rupture of the atlantochorion to the complete expulsion of the foal. And stage 3 is the expulsion of the placenta. This generally happens within 45 minutes, but it's interesting to note that it is considered retained if it doesn't happen within 3 hours. After parturition is complete, you want to make sure to get a full exam on the mare, foal, and placenta. It's very important to check for completeness, for weight, and any anomalies of the placenta. Okay, so here are some normal values to look for in the foal. First of all, proper passive transfer of immunity from colostrum is critical, so you want to make sure that they're able to nurse very early on. You want to look for spontaneous breathing within 1 minute of birth. Ideally, you want to see them sternal within 1 to 2 minutes, a suckling reflex within 20 minutes, and you want to see them standing within 1 to 2 hours. They should also be nursing within 2 to 3 hours, which once again is very critical for that colostrum and passive immunity. You also want to look for the passing of the meconium, which should happen within 3 to 4 hours, and their temperature will be 99 to about 101.5, and they're going to have a very, very fast heart rate. All right, so let's get into the case study now. Unfortunately, we don't really have that much background on the mare. We do know that the dam was a Clydesdale that entered the hospital March 14th, but didn't full out until the 25th. The owner did state that there was a possibility that she got into fescue sometime during the presidency, but wasn't sure. We also know that the gestation was prolonged at 350 days, which is about 10 days longer than average, but we should also keep in consideration that this was a colt, and generally they do have a slightly longer gestation time. During the post-parturition exam, it was also noted that there was placental edema found, but unfortunately, other than that, we don't have very much information on the dam.
One of the reasons Hope, the mare, was brought in was because the clients presumed that she had consumed fescue. Horses can be exposed to fescue through pasture grazing, their hay, or through their bedding. Fescue is toxic for horses when it is infected with a type of fungus. This fungus produces a toxin when ingested that causes a number of different effects. Toxicosis is specifically detrimental to mares in late gestation, and I will touch on those effects in a second. But it can also cause summer slump, which is basically reduced reproductive efficiency in cow-calf operations during the summer months. So it mainly affects cattle, but can also affect horses. And it also causes fescue foot, which is where you see a swelling, necrosis, specifically swelling of the pastern, and septic arthritis. It can affect cattle, but it is more severe in horses. Fescue consumption in mares in late gestation can have a number of different effects. One is that it disrupts the fetal placental progesterone production, which can cause a number of different things to cascade after it. Specifically, it causes prolonged gestation, egolalia, which is the failure of secretion of milk by the mare, edema and premature separation of the placenta, lower immunoglobulin levels, dystocia, prenatal death, and failure of the membrane to rupture at birth, which can result in what's called a red bag, which is displayed in the picture on the slide. And so keep in mind these signs for what happens when you have fescue toxicity as we continue to talk about Hope's foal and what we observed with that case.
So let's talk a little bit about the colt now. We know that he was born at the VTH at 7:55 a.m. on March 25th, and his birth was very unremarkable. Although in the charts it was noted that he didn't appropriately progress post-parturition and he was very slow. It was quiet, alert, and responsive, but he did have a slight dull mentation. It was also very important to note that he had a poor suckle reflex, which led to his inability to nurse, which also led to the failure of passive transfer. In the charts, it also said that he had some joint laxity, but he was still very ambulant, so he was able to get around. Also, we saw that there was some respiratory depression. He needed assistance to be sternal, and he also needed assistance to stand. In a positive way, he was able to pass his meconium by the end of day 1.
Our top differentials for this case are perinatal or neonatal asphyxia syndrome, sepsis, meningitis, and congenital abnormalities. As the case record said, this was essentially a textbook case for perinatal asphyxia syndrome, but the other differentials needed to be ruled out as well. Perinatal asphyxia syndrome goes by many names, including dummy foal syndrome and wanderers. The most scientific term for it is hypoxic ischemic encephalomyopathy, meaning essentially inadequate perfusion of blood and oxygen to support normal functions of the central nervous system as well as other systems. Hope's foal presented with the hallmarks of dull mentation, inability to stand or be in sternal recumbency without assistance, inability to suckle, and depressed respiration. Slow progression was also present. These symptoms are thankfully on the milder side when compared to seizures and decreased growth, other signs of this disease. This syndrome can be caused by placentitis, so the foal was already at a high risk for this due to the mare's placental edema. Septicemia was a concern as the foal could not suckle and thus did not receive passive transfer of immunity from its dam as it normally would. A plasma transfusion was performed, but IgG was still found to be inadequate when tested. After a second transfusion, IgG levels rose to where they needed to be. As Dr. Gold says, one should assume a foal is septic unless proven otherwise. There was an especial risk for this colt due to his low IgG, but upon blood cultures and gram tests, he was found to be sepsis-free. This was true each time he was tested over a period of several days. Meningitis is on the differentials list for similar reasons as PAS, namely lack of motor control, inability to nurse, and depression. However, meningitis often has a bacterial cause, and there were no signs of bacteria in the screens performed. Additionally, signs classic to meningitis were not seen, such as rigidity and pain in the neck, muscle spasms, and fever. Nor were any sorts of paralysis, blindness, agitation, or vestibular signs noted. Due to these factors, meningitis is rejected as a differential. Congenital abnormalities were considered to be a differential due to the foal's joint laxity, lack of suckle, and neurologic signs. However, these symptoms, besides the lack of suckle, improved rapidly over the first few days after parturition. If these were truly due to congenital abnormalities, we would not expect to see such expedient improvement. Diagnostics were conducted to get a better idea of the foal's overall health. An IgG snap test was performed the day after birth to check the foal's concentrations of IgG after plasma transfusion. Due to IgG being low, leading to increased risk of infections, a second transfusion was performed and IgG levels were appropriate after that. PCV was higher than desired, likely due to dehydration from the foal's inability to nurse. Creatinine was also high, which has been seen in many cases of neonatal encephalopathy. As previously mentioned, when blood was collected and cultures and gram stains performed between 326-19 and 4-1-19, all tests were negative for bacteria, leading to the happy conclusion that the foal was not septic.
The top differential for our case is perinatal asphyxia syndrome, which mentioned earlier goes by many other names as well. In short, it results from a hypoxic insult that can affect many organ systems, including the central nervous system. Principal causes for that hypoxic insult can be broken down into a few categories. For example, the principal cause could be maternal in origin, like respiratory disease or anemia or endotoxemia. It could also be placental in origin, like placentitis or chronic or acute ureteroplacental separation. It could also be fetal in origin, like dystocia, aspiration of meconium, or congenital abnormalities. Unfortunately, we don't have a definite pathophysiology for this disorder, making it difficult to both assess and manage. Diagnosis usually relies on ruling out other differentials as well as the recognition of clinical symptoms and risk factors present in the patient's history. Depending on the degree and duration of asphyxia, you could observe a variety of clinical signs with a diversity of severity. Mild asphyxia may only lead to generalized weakness, lack of interest in the mare, lack of suckle response, while extreme hypoxia could result in seizures, coma, or the loss of control of regulation of respiration and temperature. Because of the continuum of symptoms, as well as the general difficulty of diagnosing this disease, we often break it down into two categories. Category 1, where the foal is born with normal mentation but then develops clinical signs within the first 48 hours, or Category 2, where the foal is at high risk for the disorder and is born with abnormalities. Luckily, our foal here falls into Category 1, which tends to have a better prognosis, but as neonatal care improves in general, survival rates for both categories have increased. As I mentioned earlier, we unfortunately don't have a definite pathophysiology for this disorder. Much of what we know relies on work that's been done in human neonates as well as in laboratory animals, and much of that work has focused on central nervous system damage. The central nervous system usually suffers the most damage because of its high demand for oxygen and its poor regenerative capabilities. The inadequate supply of oxygen and glucose will initiate a destructive cascade that includes a massive release of glutamate, causing an influx of calcium ions into the cell. On top of that, there'll be an increased production of free radicals, a diminished ability of sodium pumps, and an altered distribution of ions, resulting in an ion gradient that draws water into the cell. This combination of swelling due to the influx of water and the apoptotic cascades triggered by the excess calcium and the damage by free radicals will kill the neurons. The location and extent of this damage can have a large range of behavioral, physical, or hormonal consequences. However, damage is not just isolated to the central nervous system. We could also see this disorder affect the cardiovascular system with reduced myocardial contractility, decreased cardiac output, or systemic hypertension. All of that could result in decreased pulmonary perfusion, which would impair the delivery of substrates needed for the production of surfactant, making the lungs vulnerable to secondary atelectasis, further reducing the ability of the body to take in oxygen and distribute it throughout the body. Diagnostic tests for our case revealed high creatine levels, which indicate renal damage, but they could also suggest adverse maternal placental conditions. A lot of effort has been put into identifying potential biomarkers like high creatine levels to help diagnose this disorder. Other popular potential biomarkers include pregnants like progesterone and pregnenolone. They act as potent allosteric modulators of GABA receptors, providing tonic inhibition to the fetal central nervous system and dampening movement. Normally, this prevents damage to the mare during parturition. However, if pregnanes remain elevated after the first 48 hours of life, they may be contributing to the reduced neurological function of the fetus. Another potential biomarker is ubiquitin C-terminal hydrolase 1. As it is primarily found in neurons and neuroendocrine cells, a high plasma concentration would indicate increased blood-brain barrier permeability, as well as the cell death of neurons. However, more research is needed to solidify the use of these biomarkers in diagnosing this disorder. Unfortunately, not having a definite pathophysiology for this disorder makes it difficult to create effective therapies. Antioxidants, including vitamin E and vitamin C, could have neuroprotective effects, and allopurinol, acting as a xanthine oxidase inhibitor, could prevent ischemic reperfusion injuries. However, there's not enough scientific evidence to prove that these improve overall outcomes. Supportive care remains the most essential. That means keeping recumbent foals warm and dry, and keeping convulsive foals in a quiet environment with minimal stimuli. Phenobarbital can be administered to control seizures and prevent further central nervous system damage and trauma to the foal. It is also important to give antimicrobial treatment, as recumbent foals are at high risk for infection, and secondary sepsis would result in a very poor prognosis. There are some studies in human neonates on the use of hypothermia as a treatment and its potential to improve surfactant function and address acute respiratory failure in an effort to improve neurological outcomes. However, there is little data that relates directly to equine, and there should be a distinction between the use of hypothermia as a treatment and a foal experiencing hypothermia as the result of a disease. A better treatment would be prevention of hypoxic events in the first place. This is of course easier said than done, but it does stress the idea that the health of the mare is essential for the health of the foal, as abnormal placentation is one of the greatest risk factors for non-survival of foals suffering from perinatal asphyxia syndrome.
Now I'm going to be discussing what treatments were given to Hope's foal. So, Hope's foal was born in the morning, and subsequent to his birth, he was given allopurinol, which is commonly given to foals born from mares with placentitis, and it helps in stabilizing serum calcium and glucose levels. He was then given a 2-liter plasma transfusion after the mare's colostrum was tested as poor quality, and so there was failure of passive transfer, so he was given the plasma transfusion. A catheter was placed, and a drip for plasmolite and dextrose was started, which has water, electrolytes, and calories. And this was placed because he was noticed to be dehydrated. And then in the afternoon, he was given Nexel, which is a kind of a general antibiotic to help with any septicemia that he could be observing or have. And then he was giving vitamin E and selenium, which is used to treat rapid respiration, profuse sweating, muscle spasms, and stiffness, as well as elevated liver enzymes. And he was given artificial tear ointment to help support his mucous membranes. And then in the evening, he was given Elevate, which is a vitamin E supplement, and so he was given this orally. And it supports healthy muscle and nerve cell function and improves his immune system and maintains a reduced level of oxidative stress. At that time, a nasogastric tube was also placed because he was not nursing, and so it was placed for helping with supplemental feedings and any other oral medications. And he was still kind of a quiet and not bright as most foals are, so he was given caffeine to increase his heart rate activity. And at that time, an umbilical dip was also performed to protect his navel from any infection. One day after his birth, so the 26th, Hope's foal was given a second plasma transfusion after they tested his immunoglobulin levels and they were still low. So they gave him this transfusion and they did another test on the 27th, so the day after, and his levels were normal. So this transfusion worked to give him his passive transfer that he failed to receive from the colostrum. And Hope's foal was also continued on plasmolite and dextrose to help with his electrolytes and all of that. He also received an enema in the morning because he had not been recorded to defecate for 1 day. And then they continued treatment with Nexel, so that antibiotic, every 12 hours, the artificial tear ointment every 6 hours, Elevate, which was the vitamin E supplement, every 24 hours, and continued the umbilical dip every 6 hours. On the 27th, so 2 days after his birth, Hope's foal was switched from plasmolite to LRS and dextrose solution, IV, which was done because his blood work showed he had a high PCV and high creatinine, so he was pretty dehydrated. So LRS is better for replacing fluids and electrolytes and not so much focusing on calories as the plasmolite previously was. So we switched to that, and then they just continued treatment with the Nexel every 12 hours, artificial tear ointment every 8 hours, Elevate every 24 hours, and umbilical dip every 8 hours. On the 28th, so 3 days after he was born, Hope's foal was doing pretty well. He had a good attitude, heart rate, respiration rate, temperature, and good mucous membranes. His appetite was also good, so he was now drinking from a bucket and no longer needed a nasogastric tube. So this whole time, he had still had that for these first 2 days. He had not nursed at all from the mare. He would not do it, and so now he was drinking from a bucket. They continued to give him LRS and dextrose solution to help maintain his fluid levels and keep his hydration. They continued Nexel every 12 hours, Elevate every 24 hours, and an umbilical dip every 12 hours. The only change that they made on the 4th day, so the 29th, was that they stopped giving the umbilical dip, and since his mucous membranes and hydration level looked good, they also stopped LRS and dextrose solution as well. On the 30th, 5 days after his birth, Hope's foal was just given continued treatment of Nexel every 12 hours and Elevate every 24 hours. He was also discharged on this day, and when he was discharged, they suggested giving him Elevate, specifically 6 mils orally every 24 hours. And I could not find in the record how much they gave him. They just said give until gone. And so this is just to continue helping to support his muscles and nerve cell function, as well as building his immune system.
We found this record overall to be very complete and easy to follow. There were a couple pieces to the puzzle that we wish we knew more about, though. The first was information on the mare. There was essentially no information besides the fact that she was brought in on March 14th, could have gotten into fescue, and that there was placental edema. We feel that our understanding of this case would have been helped by knowing why certain measures were taken and how her history may have contributed to the foal's condition. For example, why was the mare brought in so early? How long was she on fescue? What is her health history? What is her past foaling history? We would have also liked to see more detailed, dated information. While this case was very clear and informative overall, there were a few things we still wanted more information about, such as, was the foal weighed at birth, or when thereafter? The only weight in the record is 4 days later. What did the placenta look like at birth? We know edema was present prior to parturition, but how did the placenta appear after it was expelled from the body? Also, what did parturition look like? What does unremarkable mean? All that is said in the record is that the birth was unremarkable, but how did the foal truly appear on presentation?
In regards to living with a dummy foal, anywhere between 70 and 80% of cases will survive and recover well with a good prognosis and normal development later on in life. The most important considerations when living with a dummy foal, including keeping them hydrated and keeping their blood pressure up. This is going to help with tissue perfusion and oxygenation, which will prevent further damage due to lack of oxygen and also help prevent renal damage. Supportive medical management, like what was previously discussed in this specific case, is also another really important part of living with a dummy foal, as well as their environment. It should be kept clean and dry. This is going to help prevent things like secondary infections and sepsis, which is something that these foals are really prone to. And it should also be kept padded to prevent injury if the foal is having seizures. Physical therapy is another thing to keep in mind, or just not letting them lay in one position for too long, moving them around so they're laying in a different position, and then helping them get up and start to walk as their condition improves. As well as just a general attention to detail, like how much they're urinating and defecating, or signs of secondary infection or attitude changes. This is going to help catch any other problems early on so they can be treated as soon as possible. Possible complications with dummy foals include failure of passive transfer due to the inability of the foal to nurse, so it's not going to get the colostrum from the mare, and so it's not going to get the immune protection that it otherwise would have got. Sepsis is another complication that can be due to failure of passive transfer as well as other factors. And repeated or uncontrollable seizures that can't be controlled with medication or a continued comatose state is also another complication. And foals that don't improve within 5 to 10 days have a much more poor prognosis. This could be due to many things, including a difficult or premature birth, depending on what secondary complications the foal ended up having. Also, how severe the ischemic injury was to begin with, or how early the foal was treated. These are all things that could impact how the foal does long term.